Ginger Anderson. I'd like to speak to you about delirium in the hospitalized elderly. First, I want to start out by defining delirium. Delirium, according to the DSM-5, is a disruption of thinking or reasoning, such as the inability to focus attention, retain information, or properly perceive one's surroundings. Not only is this very agonizing for the family, it's also a very difficult patient for the nurse to care for. According to Rivio-Sechi and other authors, delirium is linked to a 15-day extended hospital stay, poor outcomes, and staggering healthcare costs of up to $16 billion annually. Recognizing the seriousness of this syndrome, research studies are and have been conducted, yet to date, the American College of Critical Care Medicine delirium guidelines still do not support the use of any drugs for the prevention of delirium. Fosnight has researched many randomized controlled trials, yet determined that all drugs tested have failed to prevent delirium. Yet Gillis and McDonald project 60 to 80% of the hospitalized elderly will present with at least one episode of preventable delirium during their hospital stay. Wait, preventable delirium? So if no drugs have been shown to prevent delirium, then what are they referring to? They're referring to non-drug interventions. A 2015 report by Shea states that researchers from Brigham and Women's Hospital in Boston, after reviewing multiple studies, agree that non-drug interventions may prevent up to 1 million episodes of delirium per year and save $10 billion of Medicare annual spending. Let me show you a simple visual of these interventions you can easily incorporate into your everyday patient care. Leeds University protocol has come up with being able to just have a clock in the room, also to be able to tell them the date, as well as the plan of care for the day, and to write the nurse's name down. We want to be able to help people, like Ms. Delirious here. Hopefully we'll get to her before she does, that she's upset and she's not sure if people are telling her what's going on. That's one thing that we can do. You also want to have direct eye contact when you're speaking with the elderly and make sure that they do understand what you're saying. Fosnight has also come up with when in the morning you want to raise the blinds, you want to let the sun in, so that's just another visual that it is daytime. As well as if there's a TV program or a radio show or anything that they listen to or do in their regular day, that you can try to get that on for them, so that just reiterates the time of day for them. This shawl is representing a familiar object from home to comfort the patient. Seliger has found that that was one thing that helped to prevent delirium. This can be a favorite pillow, it can be a favorite blanket, it can be a sweater that they wear, it can be a photograph of a loved one, cards from home, anything that they can refer to that can give them comfort. This walker is to mobilize our patients. The Leeds University protocol has to mobilize the patient 3 times per day. They also have, if your patient is non-ambulatory, to do range of motion 3 times per day. Rivio-Sechi has said that this alone will cause a significant decrease in the chances of someone getting delirium, just being able to mobilize the patient. Fosnight says that blocked care and low-level lighting and quieter environment during the night can help to normalize sleep cycles, which can also have a big impact. According to Rivio-Sechi, most of these interventions can be completed within 10 minutes, and others can assist too. You can have the respiratory therapist, the occupational therapist, the physical therapist, the nurse assistant, and you can also have family to help to meet the goal of these interventions for your patient. You can help by requesting that a protocol that these be implemented into a protocol in your hospital for your elderly care plans for your elderly patients. These simple interventions can save elderly patients and the healthcare system by decreasing the unnecessary loss of money, mind, and muscle. Are there any questions?
What if the patient doesn't have available or willing family to assist in this care?
Boss might suggest a sitter employed by the hospital or volunteer services set up by the hospital can assist.
What about combining drug and drug-free protocols to combat delirium?
Again, as documented by Tabbitt and Howard, there is no drugs that are recommended to prevent delirium, and some studies have shown that the outcomes to be worse when they combine the two protocols.
Other than advancing age, what are other risk factors for delirium?
According to Holroyd and Leduc and other authors, the risk factors described most are elderly patients. Diminished eyesight, difficulty hearing, malnutrition, immobility, constipation, dehydration, abnormal electrolytes, infections, and an indwelling Foley catheter. Thank you very much. So remember, don't wait for the delirium to start, prevent it.